But now we start with a first lecture, and it's really a great pleasure for me to introduce Dr. Nina Fuller-Shavel to you. I have to admit, I asked her last year to attend this meeting, but her timetable was too dense to come, and I'm so happy that I insisted on the invitation, and you were able to arrange to come for today. Nina Shavel is an award-winning physician, scientist, and educator whose work has helped advance evidence-informed, patient-centered integrative oncology, not only in the UK, but internationally. Dr. Nina Fuller-Shavel is Chief Executive Officer of the National Center of Integrative Oncology and Medical Director and Head of Integrative Cancer Care in the Synthesis Clinic. I think you founded this clinic. And by the way, I heard that you are planning a huge project to found the first inpatient clinic in Great Britain. And you showed me drafts of your project, and I was really impressed. She holds 4 Oxford degrees, including the degree in natural science and medicine from the University of Cambridge, and distinctions in MSc in precision cancer medicine and PG DIP in health research from the University of Oxford, as well as additional trainings in nutrition, traditional Chinese medicine, yoga, and other modalities. You serve as the chair of the Society of Integrative Oncology, ESIO, and in the global committee of the ESIO board member, and you are active across several institutional projects, including SIO-ESCO, guidelines on anxiety and depression. So your scholarship spans supportive care and survivorship support, immuno-oncology, and the intersection between precision oncology and integrative oncology. I'm really excited to have you here today, Nina, and the stage is yours.
Thank you very much. It's a great pleasure to be here today. And I want us to highlight the intersection between integrative oncology and immuno-oncology. So I'm going to really open up the global systems view around integrative oncology and immuno-oncology, and then we'll dive down into metabolism over the course of the afternoon. So as Boris has kindly introduced me, I wear several different hats, both within the UK and more globally within the SIO. And my background is quite diverse, and we've also published on some books on integrative cancer care, and I've even managed to get a mistletoe therapy chapter into the US comprehensive integrative oncology textbook, which they weren't going to have, so I was quite pleased with that. As you can see, again, my publication record really very much spans immuno-oncology, but looking at nutrition as well, and looking at more broader interventions for psycho-emotional care and supportive care for our patients. So these 2 figures that you will see here is really outlines some of these strategies we might consider within the IO squared approach. So IO, immuno-oncology, meets IO, integrative oncology. And there's a lot of things that we can do around optimizing these very expensive immune checkpoint inhibitor drugs that we use that carry extensive toxicities. So we want to make sure when we use them, when they're incredibly powerful and transformative for patients, that we use them well and alongside a really broad toolkit to make sure that we are supporting efficacy, but also making sure that we're reducing toxicities. So we started off with a 2024 review paper that really highlighted the need for low-cost approaches to optimize immune checkpoint inhibitor therapies. And we know that there are a number of tumor-intrinsic factors which we cannot change, but there are a number of modifiable factors associated with patients that we can change. And that might be systemic inflammatory markers, diet, and the gut microbiome. So as an overview of key recommendations, which you can again look at in the original paper in PubMed, we talked a little bit about dietary approaches. So we looked at the Mediterranean-style diet with a minimum of 20 grams of fiber based on available evidence. We looked at some of the preliminary evidence around exercise. and looked at optimizing vitamin D. And you will see some of these themes come in later on and some of the evidence behind those. We also started talking about medication reviews. It's really essential that we optimize medications in patients before they receive immune checkpoint inhibitors. And then there were some specific cautions. So again, cannabis we'll talk about later on, but it does remain a caution at the moment due to conflicting data around ICIs. There was also an emergence of data, and we'll see there's been a lot more in this field, around how do we actually modify the gut microbiome in ways that may be more accessible than fecal microbiome transplantations for patients. So I'm going to start with actually how do we assess patients when they come in, right? So we need to be looking at some of the biomarkers to think about what the response might be to ICIs beyond their tumor-related data. And we know chronic inflammation has been associated with ICI outcomes in many, many studies across multiple different tumor types. And we can use different indices. We can use neutrophil to lymphocyte ratio, NLR, PLR, LIPI, SII, SIRI. We can look at all of these composite indices to see, do we have chronic low-grade inflammation that might shoot my ICI response for this patient later down the line. So the initial evidence really came from some of the sub-analysis of key trials like NVIDIA, for example, but we now have actually the LORIS index, which is used by the NIH in the US to look at predicting immunotherapy response in patients. And while we can't do very much about patients' age, or years, or TMB, we can absolutely modify their albumin and we can modify their NLR with integrative approaches. So these are the 2 out of 6 factors that are modifiable by the things that we do. If we're looking at the more recent outcomes, I think there's been a really big meta-analysis of 6 studies which comprised over 1,100 patients that really looked at, can we look at SIRI as a really easy index we can pull from the full blood count, and can we correlate it with survival? And we know that the higher the SIRI, so higher the chronic inflammation, the worse overall survival and PFS is really. And there's been also some data around cervical cancer. We've seen a lot of data around melanoma, non-small cell, etc., but not so much around some of the gynae cancers. So it was encouraging to see that this pans out in cervical cancer as well. So again, a lot of dense data here, which you will get copies of, but across advanced non-small cell lung cancer, this just multiple different indices with chronic inflammation are associated with PFS and overall survival. So this is something we need to measure proactively as early as possible. And this is something we can actually do something about. And that's where we have the advantage in integrative oncology over standard of care, because if you come to an average, any doctor, and you've got a CRP of 10, and you don't have infection, what's going to happen? We're going to shrug, we're going to go, meh. But can we modify it with integrative oncology? 100%. And I will show you one of the examples from our own clinic. So this is something we all need to be doing. From simple full blood counts, we can get full blood count, albumin, and we can calculate vast majority of these markers across from LIPI, NLR, etc. And some of you might have seen this data from the LIPS-3 score in advanced non-small cell lung cancer. And what they've done is they actually took a really large cohort and they stratified them according to these 3 factors. This was a poor ECOG performance status, use of pre-treatment steroids, and elevated NLR over 4. And as you can see, depending on what you've got in there, you can have a 1-year OS of 78% or a 1-year OS of 11% if you have all 3 risk factors. And that's, again, something that we as doctors really need to be aware of. When we're looking at other tumors sort of beyond non-small cell lung cancer, again, these same relationships pan out across multiple tumor types. So we are looking at them in advanced renal cell carcinoma, where we know that NLR and MLR have been all associated with multiple different response markers. We can also see other things like pan-immune value coming out there. So Cali index as well for things like metastatic melanoma, which is really easy to calculate online by just having your CRP, albumin, and lymphocyte counts. So what we really can conclude from all of this is that we need to be evaluating patients when they come in on entry, being aware, of course, that our neutrophils will be knocked by things like G-CSF and steroids, so we cannot use neutrophil-dependent indices in these patients. But for those where we don't have that as a baseline, we can start calculating those. So at minimum, you need your full blood count. You can calculate NLR, PLR, SII, and SIRI, and they're the most robust associations. For lung cancer, you can also look at things like LIPI, and you can also calculate Cali if you've got CRP and albumin. So having full blood count, inflammatory markers, baseline LFTs and renal that we do for toxicities already gives us a whole load of data that we can use to manage our patients. And of course, at baseline, you must test 25-hydroxyvitamin D. If you remember nothing else out of today and you don't test it now, please test it and optimize it proactively. I also want to draw your attention to the CRP kinetics. So what we are seeing from research over the last couple of years, which some of you may be familiar with, is that CRP and NLR kinetics matter. What we want is an early activation of a targeted inflammatory response. We want an early spike in CRP or NLR, and then we want it to come back down to baseline or lower than baseline, and that is associated with the best response. So if we get an uptick in CRP and it hangs, that is associated with worse response, unsurprisingly, because we're getting this non-specific immune activation rather than an anti-tumor target. So you might want to be looking at CRP kinetics, and we're seeing this in clinical trials now, monitoring that as a prognostic marker. If we're looking at other modifiable biomarkers, I mean, I could do a whole day on this, so we're only going to touch on simple things. But there are some specific microbial signatures within the gut microbiome that are strongly associated with response. And again, this is one thing that we can absolutely do something about. We can modify the gut microbiome through nutrition, exercise, prebiotics, live biotherapeutics, and we can also look at modifying metabolic function of that microbiome through postbiotics as well. So there's a lot that can be done here. I will pick up some really key points. And really the important thing here is, for example, in breast cancer, we see alpha diversity, which has been estimated by a number of different things. So if you do a metagenomic stool test, you can get your alpha diversity done. And we can see here across two subtypes of breast cancer, whenever immunotherapy gets involved, it's associated, the lower the diversity, the lower the response, right? So this is something, again, we can easily influence your 30 different plants per week, right? Very, very easy, very non-harmful intervention that could potentially improve that alpha diversity. The other things that we can see is that having a balanced immune system in the gut really matters. So if you've got high calprotectin as well as high inflammatory markers, that will influence your response negatively. But if you've got a normal mucosal immune system with a good, robust amount of secretory IgA, that will be helpful. And again, that's all measurable in the stool test that we can do. We are now looking, instead of trying to focus on these little bits of bacteria, and we've focused on Akkermansia, and then we focused on bifidobacteria, and then we focused, etc. We are now looking at combined microbial signatures, which is really important, because ultimately it's never going to be one little keystone species that's going to be the problem. It's going to be the overall microbial signature. So one of the examples I want to highlight is TopoScore, because it's been quite robustly validated across 3 different cohorts. So you can see here, it's a non-small cell derived signature that they've started with, and then they validated that across the urothelial carcinoma and RCC there. So we know they've classified the SIG1, which is the non-responders, SIG2, which are responders. And when we combine those microbial signatures with Akkermansia, we can get a reasonably robust prediction of response to immunotherapy. Again, this is the stuff that's modifiable. If you have not tested for H. pylori in patients with your gastric carcinoma or HCC, I would encourage you to do so before ICIs. It needs to be cleared. Right? There's quite clear data now that if H. pylori is positive, both in gastric cancer and HCC, it's associated with a shorter PFS in particular, and also shorter median OS. GI infections, again, when we're thinking about how do we optimize patients beforehand, if you had somebody who had a significant GI infection, gastroenteritis, C. diff, etc., that's been associated with a higher incidence of immune-mediated colitis. So your risk for IRAs does go up if you've got a significant disruption to the gut microbiome. And we'll need to do something about it. We will need to rehab that gut microbiome to try and get that patient a more robust immunotherapy response and less risk of colitis. So here, for example, prior GI infection was independently associated with an increased risk of mortality and odds ratio of 1.6 for patients who received ICIs. So if you've got somebody who's had C. diff and has received antibiotics, we need to be doing something about modifying the microbiome. And that's really what I wanted to show you. I think when we know about what's going on at baseline with our patient, how chronically inflamed they are, we can change something for them. And we can also, when we assess the GI microbiome, change that gut microbiome to convert the impossible to possible, which is really important. So SAP, ICIs, when you do your medication reviews, everybody should be thinking SAP, steroids, antibiotics, and PPIs. And we know these are robustly associated with response. There's maybe a small amount of conflicting data, but I would say 80% plus of data is pretty consistent. So for steroids, we know that pre-treatment steroids continues to be associated with worse outcomes. And they did this Radiohead study, which you can see here, and you can see a significant curve divergence for survival between the top line here, where you've got no baseline steroids at all, and then the bottom line, which has got systemic steroid. And, again, the hazard ratio here is 1.75, so not trivial. And there are many individual studies that you will find on PubMed that basically amount to the same message. And dose matters. So when we're looking at 1 to 2 mg per kg of prednisolone, that is associated with much worse outcomes than 0.5 mg per kg. So that top dose of steroid matters. So the timing and presence and dose of steroid all matters for your patients. Antibiotics, again, this is a cutaneous melanoma analysis, which was, again, concluded unsurprisingly that antibiotic use in melanoma has been associated with an increase in mortality risk. And depending on the random effects or common effects model, it can be anything between 26 to 55%. Okay, so not trivial. Of course, we have to use antibiotics sometimes. We don't have a choice sometimes. But if we think about optimizing our patients with chronic infections or recurrent infections early, we might not have to. And again, in terms of the most recent updates, these sorts of melanoma data, again, is borne out across multiple cancer types, like we see with chronic inflammation. So squamous cell carcinoma, again, the same thing. And the timing matters. So the tighter the timing around this immunotherapy, the worse it is. So if you're doing it within 1 to 2 weeks, it's a problem. If you're doing it within even the first 60 days, it's a problem. So we want to try and make sure that we're optimizing patients in advance. Again, PPIs. Hopefully now most of us are converting PPIs to H2 receptor antagonists, I would hope, now in clinical practice. So PPI use has been associated with worse mortality across all of the cancer types you can see behind me, okay? And these are, again, non-trivial differences. And a lot of the time, patients will come to us on PPIs, and actually they have no idea why they're taking them, right? If you're thinking about it, they've just been put on them, and then people continue prescribing them, and they have no idea whether the indication is still even there. So I think it's really important for us to think about the fact that use of PPIs across multiple cohorts is associated with worse outcomes. Not only is that the case from the survival perspective, it's also the case for renal and GI toxicities. So we now have a significantly increased risk of AKI and interstitial nephritis when we combine ICIs with PPIs together, okay? And these are non-trivial risks. So we know renal adverse events are worse, and also upper and lower GI adverse events are worse when we've got PPIs. So this is why it's so important that when we are doing upfront medication reviews, we are optimizing patients, switching them to H2 receptor antagonists or considering other integrative modalities if they're simple reflux, for example. So again, this is just a very practical slide, a quick summary. So whenever you do a medication review and you're considering starting ICIs, think THAP, so avoiding steroids within particularly the first 30 days as much as possible, ideally within the first 3 months, particularly the higher dose regime. So if you have to use the steroids, try and keep it 0.5 mg per kg pred. And then look at their infection history. Do they have recurrent UTIs? If they do, we should probably be doing something about it. There's now UTI vaccines. There's killed bacterial lysates we can use to try and induce a more robust anti-UTI immune response before we give an immune checkpoint inhibitor. And I do that a lot with my patients with Euroimmune as an example of a vaccine that covers the 4 most common uropathogens. Again, if they've got respiratory problems, uncontrolled COPD, let's control that, because that's going to have an impact on antibiotic use down the line. And of course, stop or switch PPIs as well. And I would just like to highlight this paper. I really like this ASCO book. It's Gut Microbiota and Antibiotic Stewardship. If you haven't read it, it's really, really useful as a summary. I'm not going to spend a lot of time talking about mistletoe therapy because we don't have a lot of time altogether. But as we know, there's been several papers. There's been 3 suites of papers from the Network German Oncology Registry on mistletoe and adjunctive use with immunotherapy. And so across different cohorts, particularly for non-small cell lung cancer, that relationship is quite strong. Of course, we need prospective studies. So, of course, ISCA check is ongoing from what I understand. And the latest paper is here, and there will be a new update as well that looks at quality of life, and that will be really, really interesting. So you will see hopefully an update on that over 2026. But these are, really, really significant data in terms of combination of the 3-year survival rate in ICIs plus VAE, statistically significant, certainly. This is what's happened there? It's now no longer working. Let me just do that. Oh, here we go. Okay, hopefully. Good. So this is just with many thanks to Dr. Friedemann-Schad, who's presented that particular slide at ESIO Europe. And again, you can very, very clearly see the combination divergence of the survival curves there. So certainly worth prospective trial consideration, and there's other indications that we might give mistletoe therapy for, particularly when we use chemoimmunotherapy. Medical cannabis continues to be a caution because there's conflicting data. And of course, the first flag was raised by the Barcella paper, and they showed actually a worse time in terms of tumor progression and overall survival, but potentially reduced adverse events. And there was a follow-up paper from the Israel group that actually said, there was a sigh of relief because time to progression was better. But if you look numerically, they said, well, it's not statistically significant that we have an OS difference. But when I looked at that paper, statistically, if you had more patients, they would have reached statistical significance. So we still have an open question because over the last 12 to 18 months, the other two publications are directly conflicting. We've got the Canadian trial data that shows no impact whatsoever based on individual patient analysis. And then we've got a retrospective cohort from a US single center, that's MSKCC data, that shows a worse DCR, OS, and PFS. So we do not have an answer on this, and therefore discussing risk-benefit with your patients is really, really important. And again, what we need is really a prospective trial that looks at proper cannabinoid profiling, because we're not going to find a simple answer here. The CBD ratio, CBD, CBG content, etc., will have an impact, because the likelihood is that when we have higher CBD, CBG content, lower THC, lower CB2 interaction, we probably will have a better profile for interaction with immunotherapy. So let's talk about my favorite thing. Oh, what happened there? Sorry, my screen is doing all sorts of interesting things. So let's talk a little bit about the nutrition, lifestyle, and things that we can easily do with patients going forward. So when we're thinking about the nutrition gut microbiota, the first data really came out of Spencer's study, which some of you would have read, and that was looking at late-stage melanoma patients, observational data. And they basically concluded that the most PFS benefit came from having a high fiber intake. They used 20 grams as a cutoff, which is not really high fiber. And actually no probiotic use. So this is important to keep in mind because this is the first paper that established that generic probiotic, just thrown in there with immunotherapy, does not work. And then there was a multi-cohort study looking at, again, 91 patient Mediterranean-style diet. So again, we now started seeing dietary signals coming through, and the mechanism for that would be the modification of the gut microbiome and that gut immune axis influencing immunotherapy outcomes. And there are several trials that are ongoing in this particular field. And again, you will see from one of my papers, if you look that up, there's a nice, neat evidence table for different nutritional interventions and where the research is going to be going in the next couple of years. So we do have some evidence for Mediterranean diet and fiber intake, and I will show you an update from the phase 2 diet study shortly. However, there's other interventions that have been studied. So people are looking at other things like adding fermented foods, for example, adding prebiotic-rich foods. We do not have outcomes data on that at the moment. So even if we might recommend it for general microbiome support, there's now currently no data as to whether it influences immunotherapy outcomes. And if we're looking at other things like fasting regime, fasting mimicking diet, they're all being studied. So there are trials in progress that we need to watch. And out of the fasting studies, the only really convincing early data is for the 14-hour prolonged nightly fasting. And that's been shown to be associated with better outcomes in an initial report, but we need to get the full paper. Ketogenic diet is being studied with one of the ketogenic diet trials being recently discontinued. So that's, I think, direction is shrinking a little bit because of compliance issues and because of actually we are seeing more encouraging data looking at particularly the fiber, prebiotics, etc. So when we're looking at the recent updates, and again, this is just over the last year, we've seen a Thai multi-center cohort that shows if you consume a lot of ultra-processed foods and a lot of cholesterol, sodium, and high saturated fat, it's associated with hyperprogressive disease on ICIs. So this should be hopefully quite a convincing argument for patients trying to come off of the UPFs onto a whole food-based diet. And then the phase 2 diet study was presented at ASCO in 2025. And again, these are just very, very initial outcomes for patients with the new adjuvant cohort receiving most of the benefit here, unlike the adjuvant cohort. So this is something we are waiting for. So of course, the data is immature. So hopefully we'll see more publications of that over the course of this year. Vitamin D, my favorite topic. I used to be called the vitamin D lady in my hospital. And that was before it became popular. So this pre-COVID, so everybody was like, vitamin D, it's only for bones. So anyway, we now know much better. But I think it's really important for us to think about how this data progressed in ICIs. So we started off just setting a very low threshold of actually, below 50 nanomoles per liter and already seeing an impact on immune checkpoint inhibitor outcomes. And then came the Providence study of 164 patients with a multi-cancer cohort. And they quite convincingly showed that if we use 75 nanomoles per liter, there's a big difference between your vitamin D deficient patients and sufficient patients in terms of outcomes. And really, what we need to answer going forward is actually, is 75, because we're not going to keep people precisely at 75. What is the range? Is there benefit 75 to 100, 100 to 125, 125 to 175? We don't actually know the dose response because those studies haven't been done robustly. However, this data, particularly over the last year, has really robustly come up with a systematic review and meta-analysis that shows if you have higher vitamin D, you will get improved OS as an association with a hazard ratio of 0.47. So again, non-trivial. And actually, vitamin D supplementation has been associated with a prolonged OS as well. So it's really important that we test and address it and optimize it to a minimum of 75 nanomoles per liter. It also, of course, has other outcomes for our patients. Many of our patients have concerns around osteoporosis and other things. It does the same thing. 75 nanomoles per liter is a good cutoff. And the TriNetX Research Network is a huge network you might be familiar with. And again, what they've done is they've looked at multiple different cancers, particularly looking at melanoma, digestive tract cancers, etc. And again, they looked at, it's even associated not just with ICI outcomes, but significantly higher all-cause mortality if you are deficient. So we owe it to our patient to optimize that very simple thing. Physical activity, so I'm going to briefly mention it. This is a developing area. So we actually know there's been a lot of papers over the last couple of years of looking at physical activity as actually activating the tumor microenvironment. How can we turn colder tumors hotter? And so there's a lot of research that's going into it at the moment. And as we know, from the ASCO perspective, we already have a very clear guideline that anybody who is in active treatment should, which is a very strong recommendation, as we know in guidelines, should be recommended aerobic and resistance exercise. So working them up towards the guidelines of 150 minutes of moderate aerobic exercise and 2 full body resistance training sessions is essential. Now, in ICIs per se, we actually don't have a lot of data on this. So there's some really small studies coming through. So we've had one retrospective study in HCC, which showed potential benefit. There's 2 small program pilots that showed it was feasible to do this with ICIs, but actually there's not a lot of data on it. But there are trials ongoing, so we do really need to watch this particular space. In the meantime, my suggestion is we follow the normal active treatment guidelines, right, until we know better. And this was, again, another feasibility study. So this was across 8 cancer centers in Brazil. And they looked at a personalized 12-week physical activity program and found that it was feasible and it was also associated with better symptom control and quality, in terms of quality of life as well. So these are the 2 studies to watch. So I think the future of all of this isn't doing unimodal interventions, as we know, right? Multimodal works better for multiple different reasons. So I would like us to watch those 2 trials that are coming out, the DUO trial and EDEN trial, because they're going to be combining nutrition and exercise interventions. That's really likely what's going to tip us into a really good clinical effect. Here we go. And this is just a quick one to look at another retrospective study. Again, there's some trends towards clinical benefit, particularly in the high TMB tumors. The advanced solid pan-cancer study, but it didn't reach statistical significance. So we need that prospective data. Now, that's something that some of you may or may not be aware of. Actually, emotional distress is associated with ICI outcomes. There's two studies, the phase 2 Prado trial and the stress lung study, that actually show that baseline emotional distress is really associated with poorer outcomes. So if we're looking at the stress lung 1, for example, and these are advanced non-small cell lung cancer patients, if we give them first-line ICI treatment, their hazard ratio of death, if they're chronically psychologically distressed at baseline, at 2 years is 1.82. Okay? And that's something we should be optimizing, right? That's something we need to be doing for all of our cancer patients, but particularly this is clinically impactful. So what's interesting, of course, for us is then we need to have prospective data of saying, well, that's great that we spotted they are chronically distressed. What do we do about it? And I'd love to see more trials that look at mind-body interventions, not just psychological support, because mind-body interventions have complex effects. So I'd love to see yoga, tai chi, qigong, acupuncture trials to look at how we can modulate that. And the other thing I will just quickly highlight is the fact that we know that adding immune checkpoint inhibitors to chemotherapy worsens cognitive decline. So we do really need to watch it with patients and put strategies together for CRCI. Interesting enough, again, this is just more recent data on why emotional well-being matters. If we're looking at anxiety in this cohort of advanced non-small cell cancer patients, anxiety was independently associated with progression-free survival and depression and fatigue with OS. So again, proactive management, not just for the fact that we're improving patient experience, but actually from that perspective of ICI treatment. The other things I would just highlight is these issues don't go away in survivorship, okay? And if we don't manage them early, they will haunt our patients in survivorship. So this is a study on the survivorship care plans. And actually, we've seen 2 years plus down the line, there's an impact on quality of life, anxiety, and depression if we don't manage it well, as well as sexual issues and metabolic syndrome. So now I want to talk about my favorite topic, gut microbiome, because this is really fun. And as we know, the first indication of why gut microbiome mattered came from an FMT trial. So Baruch and colleagues basically took non-responders in metastatic melanoma and they transplanted them with a microbiota from responders. And they showed those previously resistant were actually able to get a good response in a significant amount of patients. So then the focus was very much onto FMT, and there's a boatload of FMT trials, but these are not accessible to vast majority of patients globally. So I'd really like us to refocus on thinking about what can we do that quite simple interventions that can be accessible. So we focused very much then on LBTs, so live biotherapeutics or probiotics is another word for it, but LBTs are different because they're designed to be studied in clinical trials to deliver specific health effect, right? Not just general well-being, which is probiotics, but LBTs are designed to deliver therapeutic outcome. So that's really where the focus has been. And I think it's really sad to see this table when I did this for the paper, because there's only 3 lots of interventions on prebiotics being studied right now. They are so common. We've got boatloads of different prebiotics, GOS, lactulose, PHGG. There's a number of things that we can use that are really easy for patients to take, yet we're only studying inulin, resistant starch, and camu-camu. Fine, but actually we need to be thinking about broadening that. And for camu-camu, I'll just highlight the ESMO data from 2025. And this was a phase 1 clinical trial that shows that if you give 1,500 milligrams of camu-camu before and just after immunotherapy initiation and continue that, it is safe. And we've got preliminary data in terms of OS as well for patients with melanoma and non-small cell lung cancer. Obviously, we can't conclude anything from that yet, but this is something to watch as it comes through. For LBPs, we have a lot more data. Now, again, it exceeds the time that I've got to talk about all the different combinations of live biotherapeutics, so I'll focus on really common single strains. So Clostridium butyricum 588, CBM 588, is the most studied LBT within immunotherapy combinations. Then again, if you look at the original paper, it will highlight all of the trials for you. But this has got data across observational studies, preliminary trial reports, as well as case-based reports. We know in terms of mechanism of action, the likelihood is it acts via butyrate, increasing butyrate production, and butyrate, of course, has an effect on modifying the tumor microenvironment more broadly, and also has an impact on reducing, potentially, the ICI-induced colitis that we can get with patients. The other thing is that Akkermansia muciniphala is a strain. It's probably not surprising any of you that this is being studied. But again, we have very early outcomes from that perspective. Let's not forget that there are easy things that we can do to increase endogenous Akkermansia in our patients. But again, we're not studying this. We're not going for low-hanging fruit here. So watch this. So that's Oncobax AK is the one to watch on the clinical trials side of stuff. Faecalibacterium prausnitzii, again, it's a keystone species in terms of anti-inflammatory response, really important, but we've only got very, very preliminary data in terms of observational significance. So we're still waiting for the trial data to come through. So the lower your Faecalibacterium prausnitzii, the less likely you get a good ICI response. Guess what fruit is fantastic for Faecalibacterium prausnitzii? Anybody know? Golden kiwi. Absolutely amazing as a prebiotic. And there's actually clinical trials on golden kiwi powder called Livo and increasing F. prausnitzii levels. So again, simple things that we can be doing for patients, and I'd love to see the data come through for that. And there's also L-lactis, which is basically coming more from fermented foods, which we have very, very preliminary data on at the moment. There's many other combinations, and I will just show you in a minute. I'll actually go forward a few slides so you can just see. These are the various registered trials currently that are going on in microbiome modification, particularly looking largely, really, at various combinations of LBPs, okay? So you have consortia products, which are multi-strain, and you have a single strain as well. When we're looking at data, I'd just like to caution you on the fact that apples are not oranges, okay, and we cannot apply one probiotic data to another, because we do that. It's really quite interesting. Patients will do that. You wouldn't dream of going into a pharmacy and just picking up a product off a shelf and going, that will do. I got a headache. Let's pick, I don't know, ranitidine or cetirizine. You know, you wouldn't do that, but people would do that with probiotics all the time. They will go into a health shop, get 50 billion of God knows what, and then content themselves with the fact they've done a good job. And the problem is, a psychobiotic is not going to have the same effect as a probiotic that manages the gut-skin axis, that manages the gut-brain axis. You can't really translate those. It's strain-specific. Like medications are specific, strains have specific effects. So when we look at this meta-analysis, it gives you the false idea of probiotics are good for immunotherapy. Which ones? Okay, apples are not oranges. And if you look at this actual meta-analysis, 5 out of these studies are all CBM588. So really, it's largely CBM588 analysis, and we cannot transpose those findings to other probiotics. So mechanism and strain matters, and if we try to lump all probiotics together, it's not really useful to us in clinical practice. We don't know what to give, at what dose, to what patients. So I'd like us to do smarter trials, really. And if you can imagine as well, thinking a little bit back towards how do we assess patients, the probiotic impact is likely to have a different impact depending on your baseline gut microbiome, right? If you actually have plenty of butyrate producers, but you have not a lot of Akkermansia or Faecalibacterium, actually, you might not need Clostridium butyric. You might need a different probiotic. So we just need to get really clever with doing precision integrative oncology trials, proper microbiome assessment, and targeted interventions to bring us into balance, eubiosis. And then I think we're going to see a lot more impact, really. This is just a quick highlight on CBM588 data, and again, you will be able to see more of that as we go through. I also want to highlight the B. fragilis is the stuff that we are sometimes not very keen on, but there's a probiotic strain, actually. So there's different strains that we'll be looking at different consortia as well. So Bio3, for example, looked at 3 different active strains. And so we will see more and more of that come through. But for the moment, if you had to take away one live biotherapeutic, CBM588 has the most robust evidence. And there's some preliminary evidence that it might also buffer the effect of antibiotics and PPIs if we give it after people have experienced those and then give them immunotherapy. So this is my glass empty. I'm really sad to see after reviewing all this literature, we have missed a lot of low-hanging fruit, really simple prebiotics. There's postbiotics is nearly non-existent. I could find, I think, 1 or 2 trials And there were small pilot studies. So why aren't we studying things like tributyrin, for example, as an example of being able to give a postbiotic to patients? Why are we doing other prebiotics which are known to modify the keystone bacteria within their response pathway? So I'd really like to see that. And that's, I think, the important takeaway from here is we need to do smarter trials. We need to expand from just focusing on probiotics to go to pre and post, and actually look at combined strategies as well, because the likelihood is, again, multimodal will do better than unimodal. And baseline really, really matters. So beyond the obvious, the other things that I would like to highlight where there's lack of evidence that we need to study is mycotherapy, so use of medicinal mushrooms. We have preclinical data in animal models that shows positive impact, particularly for reishi and AHCC, which is derived from shiitake. So again, low-hanging fruit, cheap things for us to be able to give patients to see if it modifies the gut microbiome and responds in a sensible way. And fucoidan is a really interesting one. There's some really interesting preclinical data on fucoidan and triple-negative breast cancer, if you want to look that up. But again, you can combine things like that in modifying response. So fucoidan AHCC products are actually out there already. And again, something that's an easy pilot to do for somebody who might have capacity. And the way that all of these are acting ultimately, when they modify, they do modify the gut microbiome, and therefore they modify the TME. So we see more CD8 infiltration in murine models, and we need to now carry that over and see if it translates into humans. So as a brief summary, this is what you can easily print off from the paper, and where you can see this, the dashed arrows, these are preliminary data. So you can see if you spot specific patterns on your patient's stool test results, if you have access to metagenomics testing, you can then actually apply some specific interventions. But again, we need clinical data. So I want to talk you very quickly through a case study of mine, because it's always nice to apply to patients. So this was a 67-year-old female who was diagnosed with stage 3C high-grade serous ovarian cancer. She underwent all the standard of treatment in terms of debulking, secondary cytoreduction, carbo and paclitaxel, carbogem, Avastin, all of the usual lines. And she then went off to Spain to try and get low-dose immunotherapy. Then she got ICI-induced colitis, and so they had to stop that particular treatment. And when we looked at the baseline stool test before she went off to Spain, actually, there was low Akkermansia, low bifidobacterium. Then there was further progression where she returned to the UK, and the decision from the oncological side was to try and see if we can retrial pembrolizumab because we've got progressive disease. So at that point, we actually did the evaluation that we talked about. So she didn't have any SAP problems from our perspective in terms of medications. But look at that CRP, that's 8.4. The ESI is elevated and NLI is elevated. Now, in addition to previous problems, we also have low Faecalibacterium parasitii. So the likelihood of this patient responding has dropped quite a bit. If you do the patient's LORIS, it's not fabulous. We then put in a multimodal integrative oncology intervention support. That included nutrition, prebiotics, postbiotics, probiotics, because I had about 3 weeks to try and optimize this patient before they hit Pembro. And look at this one. 3 weeks later, her CRP is 8.4 to 0.8. Right? Now, we've reclassified this patient's potential for immunotherapy response, which was interesting. And the LLI is entirely normal. She then had an excellent response, actually. She had solid partial response to single-agent Pembro within about 3 months, and CA1 to 5 normalized, and then she was NED at 6 months and continues 18+ months now on no evidence of disease. Now, what then happened is it illustrates the whole bit of colitis and microbiome is she had some SIBO, so small intestine bacterial overgrowth, and the rifaximin wasn't working quickly enough, so she added neem. And she was already teeter-totter on the point of view of diversity. So we were just trying to rehab that gut microbiome. Neem is a really good domestos, okay? So what it did is then she gave herself colitis, effectively. So you can see the calprotectin then shot up after neem to her 678. At that point, I was really keen not to give steroids because this patient's response is remarkable. And if she loses this line of treatment, there's not a boatload of other things we're going to be able to do. So at that point, we then did a lot of, again, we went back to that immuno-oncology in terms of meeting integrative oncology, and we did a lot of nutrition, prebiotic, postbiotic, the whole shebang. And you can see without steroid use, within 3 months, we had a calprotectin of 13. I didn't have to touch prednisolone at all by modifying the gut immune axis consistently, testing the gut microbiome, testing inflammatory markers, and modifying what I was doing. And there will be a case series, which will hopefully be coming out on Frontiers in the next 12 months over how we manage that. So watch out for that, because it could be useful for some of your patients. So just as a quick summary before we finish, so our practical approach, if you've got a patient starting immune checkpoint inhibitors, do your medication review, optimize them, optimize their infection, recurrent infections, optimize their risk factors. Then assess, monitor, and proactively manage the inflammatory markers, their vitamin D. We need to make sure that when they're hitting ICIs, as much as possible, their NLR, PLR, SII, CRE are as normal as humanly possible. And then we do need to start them on dietary advice in advance, right? We need to be starting to think about a whole food-based Mediterranean-style diet, 30 grams plus of fiber, minimization of those UPFs, for example, and then advising them on standard things we would do alongside exercise. And then do address and assess ACEs. Adverse childhood events are really important to ask about, and the current psychological distress is also really important to evaluate. And then you also have the ESIO-ASCO guidelines on anxiety and depression. If people are complaining about this at baseline, you can actually go through the ESIO-ASCO guidelines with them and offer them some of the support that's guideline-based alongside psychological therapy. Medication review, we've talked about already. So I think that's something that we need to be thinking about. So SAP, then ask them about cannabis, and then considering mistletoe therapy. And then future directions, I'd really would like us to do more smarter trials. I think we are so used to platform trials, basket and umbrella in conventional precision oncology. Why aren't we doing this in integrative oncology? Particularly that microbiome-directed intervention is really prime for using those trial designs to be able to do a smarter way of assessing, and then personalized integration of those simple strategies like prebiotics, probiotics, postbiotics for our patients without having to FMT them, because that's really not going to be sustainable for the majority of the world. So I'd really like us to start thinking a little bit broad about, can we do this personalized multimodal prehab? And then can we support patients effectively? And can we just tease out the important bits of data? Which exact bit of exercise might be useful beyond the normal guidelines? Can there be other nutraceuticals that can come in and modify that response? So we use nutraceuticals very commonly for modifying patients' NLR and TRP as an example. Well, let's study them in combination with ICIs and see what we can do at low cost. And let's think about broader than just fermented foods and prebiotics. What about polyphenol content, right? Polyphenols influence the very keystone species we talk about here with ICI. So let's think about how do we do a high polyphenol diet as an example. And of course, mind-body approaches. So beyond psychological support, is there other things that mind-body approaches can bring to us that can modify the patient inflammatory status, their cortisol, the immune checkpoint inhibitor response, etc. So hopefully this has been a useful practical jaunt for you. It's a lot to cover in 45 minutes. You might be a little bit processing that for a little while. But I think the key take-home point is there's a lot that we can practically do. There's stuff we cannot modify in terms of tumor-related factors and immune checkpoint inhibitors, but there's things that we can do. So let's assess and address inflammatory markers and vitamin D. Let's think SAP and optimize our patients in advance. And let's do basic multimodal prehab support, Mediterranean-style diet, 30 grams plus of fiber unless contraindicated, exercise, psychosocial support, simple things that we can do. And if we get any further data, if we have opportunity to look at patients' microbiomes, let's do clever interventions rather than checking in general probiotics. And watch the space for further research, remembering that apples are not oranges, and we need to be really, really critical of LBP data. Thank you.
So thank you very much for this wonderful presentation. So I think we will all download your paper because it's very clear. It's almost like a guideline. So congratulations for that work. And we certainly want to see all the results of that lacking studies, which you are saying. So that's very important, I think, to have clear in mind in our day life. We lack a lot of data evidence. So we may, start to make more research on that. Yeah. Are there any questions from the audience here or online?
Everybody's turned into silence.
So I will start and then we get rolling, okay? So the multimodal rehabilitation is a fantastic concept, which we also know, for preoperative, like for example, for ovarian cancer, albumin, etc. So what is the time frame you would recommend? Because sometimes we are under pressure or the patients put us under pressure to start therapies. So what would be the timeline?
So I don't think we actually know what the timeline we can recommend, but I've just shown you in one clinical case that 3 weeks can be enough actually for patients if we do a really good job of it. So if they can give us a bit more time, depending on what they're on. So for example, if they're on baseline steroids and PPIs, and maybe we've just given an antibiotic, we really probably want a minimum of 30 days. That's probably data-wise is where we want to end up. And that might give you an opportunity to then optimize the vitamin D, the inflammatory markers, etc. So I'll say 4 weeks is probably, if I can get 4 weeks, is my minimum. But again, ultimately, it's about balancing that clinical risk benefit. So there is no perfect, but I would say 4 weeks gives you enough time to do quite a lot, actually, if we do multimodal input.
Okay. I think it's a very good time. We even know from some American studies for hematological diseases, but this is not always applicable for solid tumors. The longer we wait, the better is the outcome. We know it from corona. We learn a lot from lymphomas and also from leukemia. So maybe we should also try to explain. Well, we have to learn this as well as doctors to not, panic. For starting, but that's a very good point. Thank you.
Yes, so for example, LIPS-3, as we know, if you have somebody who's got poor performance status and you're thinking, gosh, you'd really benefit from ICI, putting it multimodal prehab, giving them 2 months, actually, could completely transform the outcome. You haven't then lost that line of treatment or started and went found it was completely intolerable. So I think whenever there's wiggle room, but I would say actually there's quite amazing things that can be done with patients in 4 weeks' time. Had somebody, as an example, who was bedbound effectively at the beginning when we were starting, 4 weeks later was doing 6,000 steps. But that does require a lot of that intensive multimodal rehab. So exercise, starting with, bed exercise, right? Now they're walking. Nutrition, I had her on weekly blood tests because I needed to know what we were doing was working, what wasn't working. So things like that, I think quite intensive monitoring really pays dividends later down the line.
Excellent. Any questions, comments? Yes.
You made a really good job in giving an outline on all that we discuss with our patients, also in 30 minutes, because the topic is really big and great. Now to the microbiota, I have one comment. I think it's really a pity that we know about so many germs that you have also mentioned, but we actually in practice can't cultivate most of them. We can only maybe cultivate these Clostridium species or Akkermansia, but there have been many papers around. We can only trace them in signatures, but do you know more of this problem?
Yeah, and I think this is the reason why metagenomics has really overtaken 16 sRNA, really, from that perspective. And both these methods have strengths and weaknesses, right? There is no one perfect method, unfortunately. If I could do a stool test in both methods on all of my patients, I would, but it's prohibitive financially. So if I want the broadest test, I will now use metagenomics. It will give me alpha diversity. It will give me microbial richness. A lot of these tests will also give you secretory IgA, calprotectin as a baseline, which is great, elastase, etc. So they have that component on top of metagenomics. So using those sort of really broad clinically useful tests can be useful. And then it's important that we do serial monitoring. So this is really where I talk about precision oncology meets integrative oncology. The idea is here that I'm not assuming that this baseline will magically change because I do something. We will serially monitor that and see how it improves. But, I have seen alpha diversity jump just after 3 months of, targeted nutritional intervention. We've seen correction of Akkermansia up to normal levels. And again, even with things like Akkermansia, the advantage of it is we need it to be in the Goldilocks zone, right? Too much or too little is a problem for ICIs. If you have too much Akkermansia, there's too much mucin degradation, and it's a problem. It's actually associated with worse outcome. So that bit of us getting things right can only really be done when we do testing. And I know it's not available to everybody at the moment, but I'm hoping the more we can do this and the more what they've done with the TOPA score here, actually, if you read the full paper, they've taken the metagenomics test and then they've created a much smaller 16S rRNA test that could be applicable in clinical practice that will give you an answer, not in 3 to 4 weeks, which is standard metagenomics pipeline, but about 1 to 2 weeks, which is clinically relevant right there. So that's what we really need to see in the future is top of score type stuff where we say we're going to do a big test, and then we're going to, how can we shrink it down to give me an answer in a week for quick turnaround time so I can act?
Thank you. So we have a question from the audience online, which is actually almost 1/3 of the whole audience.
Wonderful.
So it's very, yeah. So currently the guidelines do not support measurement of microbiota in stool, and intervention trials report preliminary data and no sustained change of microbiota. Do you plan clinical trials on that?
I am, yes, but funding is a problem in the UK, as you can imagine. So, in fact, I'm hoping I might be able to get a project in Oxford on that. So guidelines don't support it for multiple different reasons. Number one, we actually know very little about validating those signatures across multiple cancer types. Topper score is quite recent. It really just came out last 18 months. So that's part of the reasons we need to have more robust data, more validation sets, realistically. And then we need to make it clinically applicable and cheap enough for us to conclude that within our healthcare system it's cost effective to apply. We also take a step back of the fact that when we do have this data available, for some of our patients it is available, they're keen to do these sorts of tests, then I'm not going to take that option away from them. If I know how to interpret them and modify it and I can test and show an impact, then I will do so. So I think that's also really, really important. And sometimes makes me laugh when we apply slightly different evidence standards to different things. So do you know what the pivotal CAR-T trials, what the N number is for pivotal CAR-T trials? Under 20 people, okay? And then, so compare that, and that we're happy to give this and put people in ICU based on under 20. But God forbid we do microbiome testing. So we also need to think about risk-benefit here, a little bit pragmatically. So if I do have somebody who can have access to metagenomics testing, and I've got somebody like this lady here, for whom there are very limited options now, okay? We're platinum resistant, we are down a creek from that perspective. And yes, okay, maybe she's folate receptor positive or not, maybe we'll have MERV, but maybe not. So when we have limited options and we really want to maximize ICIs, I will do absolutely everything pragmatically to try and optimize this for the patient. But yeah, we need more data, we need more funding, and we need smarter trials, not just let's just chuck a probiotic into anything and decide what happens. We wouldn't do it, we wouldn't treat non-small cell lung cancer without understanding genetic background, right? Nobody would go, oh, I don't know a driver mutation, let's just chuck something in there. But we will do that with microbiomes. We will, without knowing the baseline set, we will apply an intervention, smarter trials, look at precision oncology designs, and let's just do that sort of thing. Yes, that's my very long-winded answer.
We have time for one more question. Yes.
Just a practical question first. Thank you so much for your super meaningful lecture. Nina, when it comes to the stool or microbiome monitoring, how often do you do a stool examination?
So usually 3 months is probably the shortest timeline, I would say, because you need to put enough meaningful change. And what's interesting is people will say adult microbiome is not very malleable, right? Which is, I think, that point from the test saying it doesn't change that much. It really does. We actually have data from dietary interventions that shows if you change your diet profoundly, you will see changes within a week, actually. So we know that fasting will change your gut microbiome, not only just what you eat, but how you fast and when you eat will change it. So I would say 3 months, usually I find that that's enough to see an impact. And then we would do that at intervals depending on what we've got to correct. So if I still got a lot to correct at 3 months baseline, then I might do it for another 3 months for a couple of times. And then after that, it's as needed. So if somebody then gets a boatload of antibiotics, if somebody then gets an immune-related adverse event, or if they get a GI infection or any other inflammatory stimulus, I might want to see how that's responding. So it is a living, dynamic organ, right? That's what the microbiome is. And we do need to understand it to be able to get the most out of that relationship.
Thank you.
So we have another 5 minutes. Then if there are no other questions, I would just have the last question. I'm just thinking globally, so global health. And then now also other countries, let's say middle-income countries, they will start to get access to immunotherapy. Yeah. They have a completely different diet, and they have much more use of antibiotics because they have much more infectious disease, which we don't have. or at least not as much. So that would be interesting to know if there are some results from other global area or other regional areas where their diet and antibiotics, they are much, much more present than I. Do you have any
I don't think we have any specific results on that, but I think what's interesting is that we will see patterns depending on pockets of people, I would say, and pockets of behavior. So we know, for example, if you look at the traditional Japanese diet as an example, or traditional African diet, some of them can be really high in fiber, actually. So even if you've got more infectious disease, maybe more parasites and other things like that, can that be countered? We don't have an answer to that, actually, because they also don't have access to a lot of UPFs. They don't have access to some of the other things that we've got. So I think it will be interesting to see. I think that there's some really low cost, this is why I'm talking about low cost, easy interventions. Saccharomyces boulardii as a probiotic, for example, can reduce your risk of C. diff when it's combined with antibiotics. We can also use it to improve your secretory IgA, so your mucosal immunity in general, so make you more resilient to GI infections. And it changes some of your gut microbiome markers as well. It doesn't need to be refrigerated. So that's something that's intervention that's it's cheap. So it can be put into LMIX quite easily to modify some of those things. PHGG, some of those prebiotic fibers are really easy to put into foods or drinks from that perspective. And again, that can modify stuff. So I just really want us to turn away from the very high-tech stuff of running, really tens of FMT trials, yet 3 on prebiotics. It's just completely unbalanced. We need to be thinking about LMIX. We need to be thinking about our patients in general and the healthcare system costs. If we're looking at ICIs at, say, £85,000 per patient per year, right? And now we're adding FMT costs to try and convert them to responders. Why not try something that's a little bit lower level? So I would say it'd be interesting to see the data. We need robust documentation of nutritional intake and fiber intake as an example. Robust concomitant medication administration, which is important. And blood tests are going to be quite hard to get in some of the LMICs consistently as well, because access to care could be, 100 miles down the road, actually. So I think it'll be a really interesting area how we coordinate that data.
Thank you. Thank you very much. So I think we need to, continue. Thank you for visiting us and bring the sun.